He woke up at 3 in the morning with his own hand around his throat. Not someone else's hand. His left hand, the one he had used that day to sign documents and eat dinner and turn off the bedside light, was pressed against his windpipe with a force that was deliberate, that was sustained, that had nothing to do with anything he had intended or wanted it to do. He pried it away with his right hand. He lay in the dark for a long time, breathing carefully, his right hand gripping his left wrist. His left hand pulled toward his throat again. He held it down against the mattress. He did not sleep again that night. He lay there until the room lightened and the birds began outside the window, holding his own left hand still. And he did not tell his wife, who was asleep beside him, that any of it had happened. Tom was 53 years old, a retired school teacher from rural Oregon. He had been a calm man his entire adult life. Methodical, patient, the kind of person who taught for 27 years in the same school because the constancy suited him. He had no history of sleepwalking, no history of sleep disorder, no family history of neurological illness. He had retired 2 years earlier in reasonable health, with manageable blood pressure and the ordinary collection of minor complaints that accompany a body in its early 50s. Nothing in his history prepared him for what began that autumn. The first incident had been easy to explain away. He had woken 6 months earlier to find his left hand pressing flat against his face, covering his mouth and nose with enough pressure to disturb his breathing. He had assumed he had rolled onto it in his sleep, that the awkward position had caused some reflexive tensing. He repositioned himself and fell back asleep and did not think about it again until the second incident 3 weeks later. He woke to find his left hand gripping the edge of the mattress and pulling a slow, steady traction that had already moved him several inches toward the side of the bed before he came fully awake and understood what was happening. He grabbed the bed frame with his right hand and stopped himself. His left hand continued to pull for another several seconds before it released. He lay still on the mattress and looked at his left hand. It was resting now, relaxed against the sheet, indistinguishable from a hand that had never done anything unusual. He did not tell his wife. He did not tell his wife because he did not yet have a language for it, and because the gap between what he had experienced and what he could expect anyone to believe was, at that point, still wide enough that he was not certain he believed it himself. What had happened was not a dream. He had been fully awake on both occasions. His left hand had been doing something that he had not authorized, something that felt directed and purposeful in the way that intentional movement feels directed and purposeful, coordinated, goal-oriented, sustained, but which had originated from nowhere he could locate in himself. It was not a tremor. It was not the random, involuntary firing of a muscle group responding to a misfired nerve signal. His left hand had been trying to accomplish something. He had simply not been the one trying. Over the following months, the incidents occurred with increasing frequency and increasing intensity. The hand pulled at his pillow. It scratched at his face while he slept. It moved toward his wife on 2 occasions in ways that frightened him badly enough that he began sleeping with it tucked under his body, using his own weight to keep it still. When that failed to contain it completely, he began binding it loosely to the bed frame with a soft cloth, a measure he described to no one, that he maintained every night for 2 months before the incident that ended his silence. He woke to his own hand at his throat. He told his wife the following morning. He showed her the marks. He described every incident he had concealed from her over the previous 7 months, in the order they had occurred, without omission. She listened without interrupting. When he finished, she took his left hand in both of hers for a moment without speaking. Then she said, "We're going today." The GP had not encountered this presentation. He referred Tom to a neurologist in Portland without delay, noting in the referral that the patient was describing what appeared to be complex, purposeful nocturnal movement of a single limb with no awareness or control. The neurologist in Portland had seen 2 cases of what she suspected this might be. She asked Tom detailed questions about the character of the episodes, whether the movements seemed random or purposeful, whether he had any awareness of them as they occurred, whether he experienced any sensation in the hand during or after an episode, whether there had been any other changes in the preceding months. There had been. He had been slower to retrieve words recently, pausing mid-sentence in a way that was new, and that he had been attributing to the ordinary cognitive deceleration of aging. He had stumbled twice on flat ground without any mechanical reason. No step, no uneven surface, simply a misfire in the sequence of walking. He had been sleeping more lightly for months, waking multiple times per night, which he had attributed to his age and to the anxiety he was managing about the hand. The neurologist ordered an MRI of the brain. The scan showed abnormal signal in the corpus callosum, the thick, dense band of nerve fibers that bridges the left and right hemispheres of the brain, carrying the constant traffic of signals that allow the two sides to coordinate their activity. The abnormality was located in a specific subdivision of the corpus callosum, responsible for transmitting motor coordination signals between hemispheres. The pattern was consistent with demyelination, the breakdown of the myelin sheath that insulates nerve fibers and allows them to conduct signals efficiently. The same process, in different regions of the nervous system, underlies conditions including multiple sclerosis. The neurologist explained the mechanism carefully. The corpus callosum, she said, is the communication pathway between your hemispheres. When that pathway is intact, your left brain and your right brain are in constant dialogue. Your right hemisphere, which controls your left hand, knows what your left hemisphere, where language and voluntary decision-making are centered, intends. They coordinate. The hand does what you mean it to do. When that pathway is damaged in the motor coordination fibers, the right hemisphere can begin generating motor programs, sequences of movement that are internally coherent, that have an organizing intention behind them. Without those programs being integrated with conscious will, the hand acts, but the acting is not connected to anything you decided. Tom asked the question carefully. He said, "So my brain is telling my hand to do this, just not the part of my brain that I have access to?" The neurologist said yes. That was an accurate description of what the imaging suggested. The condition had been formally described in the neurological literature since the 1970s, though cases had been noted earlier. It had been named alien hand syndrome, a term chosen for clinical precision rather than drama. The hand is not responding to an external force. It is not controlled by a separate consciousness. It is executing motor programs that originate in the patient's own neural tissue in a hemisphere that has become functionally isolated from the hemisphere where the experience of voluntary intention resides. Tom said, "It feels like I'm sharing my body with someone who doesn't know I'm in here." The neurologist wrote that down. She had heard similar descriptions before. She found them clinically useful, not as metaphor but as testimony, as evidence of what the subjective experience of the disconnection actually produced. Subsequent testing identified an autoimmune process as the likely driver of Tom's demyelination. This was, from a treatment perspective, a more tractable finding than a structural lesion or a progressive neurodegeneration without modifiable mechanism. He began immunosuppressive therapy within 3 months of diagnosis. The nocturnal episodes reduced in frequency significantly over the following year, though they did not cease entirely. He learned to manage the nights pragmatically. A soft wrist brace worn while sleeping, limiting the range of motion of his left hand without causing discomfort, became the nightly ritual that gave him back something close to normal sleep. He wore it without resentment. It was a practical accommodation to a practical problem, and Tom was, at his core, a practical man. Alien hand syndrome remains one of the more philosophically unsettling conditions in clinical neurology. Not because it is common, it is not. And not because it is invariably dangerous, it is not. But because of what it makes visible about the nature of voluntary movement and about the implicit assumptions that underlie our experience of ourselves as unified agents inhabiting a body that does what we intend. We do not, under ordinary circumstances, have any reason to question whether our hands are acting on our behalf. The act of reaching, the act of gripping, the act of releasing. These feel like expressions of intention because, in a functioning nervous system with intact interhemispheric communication, they are. The intention and the action are integrated so seamlessly that the integration itself is invisible. Tom's left hand revealed the seam. It reached without his reaching. It gripped without his gripping. It pulled toward his throat in the dark with a purpose that had a neurological origin and a measurable physical cause. and no relationship whatsoever to anything he wanted to happen. And he was there the entire time, awake, aware, fully present, unable to make it stop. That, in the end, is what stayed with him. Not the fear of what the hand might do, not the diagnosis or the treatment or the long process of recovery, the experience of being inside his own body and not being in control of it, the certainty that something in him was acting, and the equal certainty that the something was not him.